Okay, hi guys. Welcome to this week's DU teaching, which is a bit of an impromptu session. I'm going to be talking about adult congenital heart disease. Why am I talking about adult congenital heart disease? It seems really obscure. It's actually not, because there are now, at least in the US, and I'm pretty sure similar numbers in Australia, there are now more adults with congenital heart disease than there are children. And there's a good chance that you're going to see something. So you might not see the original congenital heart disease that they're born with, but you'll see the sequelae, the complications of repair, and rarely, I think, you'll see undiagnosed congenital heart disease. And things that can escape diagnosis into adulthood would be things like a bicuspid valve, or a VSDs, ASDs, and very, very rarely things like Epstein anomaly. But what I'm going to be talking about, I'm going to go through two cases today, and one of them is tetralogy of Fallot and the other one is bicuspid valve. I'm talking about them because they're actually relatively common. So tetralogy of Fallot is about 10%, up to 10% of all congenital heart diseases. And I think it's pretty interesting. And I've only been at Nepean for 6 months, and I've seen a tetralogy of Fallot case, and I've seen a bicuspid valve with a coarctation aorta. So if it's common enough that I've seen it in my short time here, then I think it's reasonable to talk about it. And these patients land in ICU for various reasons. So this first case is pretty interesting. First, I'll just go through a little bit about the anatomy. So everyone thinks that tetralogy of Fallot is, it's actually should be called tetralogy of Stenson, because this Danish guy called Stenson described it 200 years earlier. But anyway, it's actually just one thing. It's not four things, it's one thing, and then the consequences of that one thing. So I'm just going to draw on here. Let's see if this works. Okay, so here you've got, your normal heart. So what happens is in the developing heart, you actually get this.
Did you free text draw that heart beforehand?
No, God, no.
That's bloody amazing in paint. You're a genius.
I mean, I could, but I didn't.
I want to run for my wall.
No, I'm not that good. Let me yeah, okay. So this part of the septum here, so this is called the infundibular septum, part of the outflow, right? Because you've got the pulmonary valve here, the RVOT, right ventricular outflow here, and the left ventricular outflow is here. Here's the aortic valve, and here's the pulmonary valve, aortic valve. So what happens is, let me make this a bit bigger. This part of the septum actually develops over here. So it goes here. So then you have, just gonna rub this out. So then you have this septum developing here. And as a consequence of that, you get RVOT obstruction. And that's the hallmark of tetralogy. And that can extend to any point up to the bifurcation, and it can be at any severity from just a mild stenosis to a complete atresia. So just a complete obstruction here, for example, you can get pulmonary trunk atresia, pulmonary artery atresia, and then the flow is dependent on a PDA at birth. So that's kind of the range of RVOT obstructions that you can have. Okay, so that's the first thing. You get, that's the first classic of the four tetralogy signs or features. So because this septum developed all the way over here, that actually pulls the aortic valve with it. So then the aortic valve develops over here. That's a terrible aortic valve. So it develops over here. So then you get the overriding aorta. So it overrides the rest of the septum, which develops normally. And then with that, you get a malalignment VSD in here. And then because of the pressures, then you get the RV hypertrophy. So those are the 4 features of trilogy, right? Right ventricular hypertrophy, overriding aorta, VSD, and RV or pulmonary atresia or some sort of RVOT obstruction. But it's actually just one thing that's maldeveloped, and everything else is a consequence of that. Okay, so what happens when they repair this? Let's go back to the original. When they repair the tiny little, so the pulmonary valve doesn't develop properly either. Usually it's like bicuspid or not even there, or completely absent, or just not really functioning well. So this pulmonary trunk, what they do to open it up, they cut like a little diamond shape in there. They cut that, open it up, and then they put a patch in there, like some pericardium or something like that. So and then open it up. So it's a little bit more normal. The problem is that they don't actually fix the valve. Like there's nothing to fix. And even if so they do this at about like 6 months of age. And if you put in a valve at this age anyway, it wouldn't grow with the rest of the heart. So you'd need multiple redos. So basically it's normal. What I'm getting at is normal to have pulmonary regurg and a non-functioning pulmonary valve after a tetralogy of fallow repair. So this is what you should be expecting in your patients if you see them. And what your job is to figure out the severity of the regurg and whether there's any downstream effects from that. And there's something else I was going to mention about that. Oh, there's often residual VSDs as well, because they fix the malalignment VSD, but there's often residual VSDs as well. Okay, so that's the anatomy explained. Okay, so this is, okay, so Ben, why don't you take us through this picture?
Yep. So I'm looking at parasternal long, and position looks okay. I'm assuming it's a patient that's got a repaired tetralogy of fallow. Based on
which you know, that's not something that they wouldn't know to tell you.
I'd like to think that's documented somewhere. So I'm just going to increase my contrast a little bit.
Yeah.
So with regards to the left heart structures, the left atrium appears to be a reasonable size and a normal size, and the left ventricular cavity looks fine. The posterior wall, inferior wall, I can't tell whether it's all, sorry, I'm pointing at my screen. I can't tell whether it's all like free wall or whether there's a, whether that's muscle riding off one of the cusps, but it looks like there's a, yeah, right there.
That's just pat muscle. Okay, so right. What wall is this, since you mentioned, what wall of the left ventricle is this?
It's going to be, is it infralateral?
Yeah, good. And so what's this wall?
And so that's going to be anteroseptal.
Yeah, good. Okay.
Anteroseptal, infralateral, and I guess I'm slightly off axis then because I can see the pat muscle when I probably shouldn't be able to. Yeah. Left ventricle from here makes the interpreting the rest of the LV a bit harder, but I'm assuming the cavity is normal size. Mitral valve looks to be perhaps looks a little calcified, but looks to be opening okay. And can't really see the aortic valve. There are right ventricle over at the superior aspect of the image looks enlarged.
Yeah, it's basically, it's almost the same size as the LV.
Certainly, yeah, its dilated ratio would be greater than 1:1, I'd say, RV to LV.
Okay, cool. All right, and let's move to. Okay, so this is the RV inflow view.
Yep.
So from that parasternal. So what do you see here?
So the most striking feature is looks to be significant regurgitation across the valve. I mean, I'm struggling to appreciate any significant structures between. I'm struggling to appreciate the valve due to the turbulence and the color.
Okay, let me show you. That's fair. I'll show you the 2D picture first. So that's the valve. So zoom. So this is an unzoomed view. It's the same view with the color on it.
Yeah.
This is a zoomed view of the valve, and then there's the color on it. So okay. What would you like to see from here?
So what this is showing then is tricuspid regurgitation, and so it'd be nice to see gradients associated with that, determine the gradient associated with that, and then go on to further look at the RV, I guess, but let's see the pulmonary pressures. So I'm suspicious that based off what you've shown me so far, that there's a large right ventricle, evidence of tricuspid regurgitation, so I'm suspicious of pulmonary hypertension, secondary to probably long-standing PR. Yeah,
does PR give you pulmonary hypertension?
No, but it could give you, clinically, it can give you right ventricular enlargement from volume over content, and then develop, will you develop tricuspid regurgitation as a consequence to that?
Yes, yeah, that's right, yeah. So because these tough repair guys don't really have a pulmonary valve, yeah. Forward flow is reliant on maintaining the low pulmonary vascular resistance and low pulmonary arterial pressures. Otherwise, their forward flow is impeded. So that's where it gets really relevant for us in ICU, because intubating them is really, you need to avoid it. Yeah. Okay, cool. You just mentioned you wanted a Doppler. Yeah. What do you think of that?
Velocity 2. So this is, I've forgotten my equation. Can't recall. Can't tell you anything further.
Well, it gives you the pressures here. So what do you think of the trace, the shape of the trace?
So I think that although there's some presumable beat to beat variability, I think it's the shape of the trace is.
Is that normal?
I feel like that's a loaded question. I was going to say yes, but now I want to say no.
Lewis, why don't you take over? Help him out.
No worries. I think the proper terminology, correct me if I'm wrong, is the V cutoff sign. It looks like it's not a parabola. It's a sharp sort of acceleration, deceleration of the continuous wave. So that's suggestive it's severe TR.
So what you'd expect from both mitral and tricuspid regurg is a nice parabolic shape in the regurg, even like assuming it's not severe. Once it gets to this V shape, both of them they have a V cutoff sign in it. That's an indication that it's severe. And then don't forget to ask for other views. So I'd like to look at it in another view, because what are some of the other signs of severe? Like how else would you confirm that this is severe? So you're suspecting it, that are severe. Remember that the velocity itself and the pressure doesn't tell you anything about the severity of the regurg. It just tells you about the pressure differences, which here is actually much lower than you'd think, because not much lower, but when this regurg is severe, it's lower than you think because the pressures equalize. So his right atrial pressure is going to be high as well. So the difference between the right atrium and the right ventricle, which is all this pressure gradient is going to be lower than you think. And then it's actually not very accurate to work out your pulmonary pressures from it. Once you have like free-flowing TR, this isn't really free-flowing TR, but once you have free-flowing TR, like, it doesn't really tell you that much.
Well, I would like to see other views then. And I'd probably look for downstream effects as a feature of severity, so reversal of hepatic vein flow.
Beautiful, beautiful. Okay, so we do have that. There we go. Okay, so I'll just show you the color Doppler, and then this is the.
Cool.
What do you think?
So timing that looks like systolic reversal of the hepatic vein flow. So that is consistent with severe TR.
Yeah, it's pretty pretty prominent systolic reversal too, isn't it? So so everything's, well, the majority of the flow is supposed to be below the baseline, because you're looking at I know you know this, Lewis, but for everyone's benefit. So when you look at the hepatic,
you assume.
you put a pulse wave Doppler in the hepatic vein, and as you can imagine, the flow is supposed to be going towards the heart, not back up towards the probe. So the flow should be below the baseline. So this is just after systole, looking at the ECG, just after. So that's the systolic wave, and it's reversed. So it's going upwards instead of downwards. So both systole and diastole should be going downwards. And here we have systolic reversal. And that automatically makes it severe. And that's true for every kind of valve regurg. You look for systolic reversal in somewhere up upstream, kind of. You look for reversal of flows. So for example, for mitral valve, it will be in the pulmonary veins. So it looks exactly the same as this, except flipped upside down. And then for severe AR, you look for diastolic reversal. And I assume for pulmonary regurg, you could look for diastolic reversal in the pulmonary artery, but I've never seen that, and I've not done it myself. Good. Okay, so we've established we've got severe TR, which is probably because his RV is so dilated. So why don't we have another look at that? Here we go. So really, really dilated RV. There's a pacing wire in there because one of the other complications they get is, very common complication is they get a lot of arrhythmias, and one of the reasons these people die is from sudden cardiac death, presumably from arrhythmias. So it's not uncommon to get a pacing wire in there and an AICD. He actually, this gentleman is about 50, and he actually had an arrest before the age of 30 while he was playing football. And that's when he got this AICD put in. And that's because of the disruption to the conducting pathways. As you can imagine, as the right ventricle dilates, you can get some disturbance to the conduction pathways. Okay, so some other signs that you might look for. So what do we, Lewis, I'll go back to you. What do you think of that? Can you tell me about that one?
It looks like the ejection fractions sorry. So that's parasentinel short through the mid-paps. The left ventricular ejection fraction looks like it's reduced, probably moderately impaired.
Yep.
And I'd be looking to get a sense of what the septum's doing to look for some features of volume and pressure overload of the RV.
Slightly adjusting. There we go. So a slightly better picture.
Oh yeah, yeah. So that looks more like what I was expecting, in that there is some flattening of the interventricular septum, and I would normally pause that and just scroll through it slowly so that I can actually time it to the cardiac cycle.
Okay, so I'm going to scroll through. So we're in diastole here.
Yeah, so diastolic flattening of the interventricular septum. So so volume overloaded.
Yeah. Perfect. Yeah. So it's more volume overload, whereas if it's flattened throughout the entire cycle, then it's volume and pressure, or at least just pressure. So no. Okay, so the other thing I wanted to show you guys was so this is a short axis view, just looking at that TR again, which is pretty significant again. And then again, Doppler traces show the same profile. And then you can also look at it in the apical four chamber. And again, so that's very clearly severe. It's taking up more than 50% of the right atrium. And then again, the Doppler profile. So in multiple views, the Doppler profile looks the same, and the color Doppler is indicative of severe when you can see the atrium, and you can make a judgment call about how much of the atrium it's taking up as well. They're kind of the eyeballing measures of severity that I use, and then you can quantify things, of course.
Can I just ask a question, Benny? Sorry. I probably should know this, but the percentage of the right atrium, or percentage of the atria that's taken up with the regurgitant jet, is that dependent on the atrial size? Like, is there a caveat there that severe dilatation invalidates that measure, or?
Not that I know of. I've not heard that mentioned.
No, neither have I, but I just was wondering whether you'd heard anything.
I don't think it would, because I mean, if the TR is really severe, then you would expect some right atrial dilation over time. So yeah, no, I don't think so. Good question.
But that jet's eccentric, isn't it? So it's always going to be the supposed.
No, it's not eccentric. No, it's very wide and diffuse. But it goes everywhere. To call it eccentric, like you would have to take out this bit in the middle. Do you know what I mean? There is central TR there as well.
Okay.
Yeah. Okay, and then this is the same short axis view at the aortic, at the level of the aortic valve, which you can't see very well, and I think it's because of the VSD patch repair, which would be around here. So on this one, you can see the pulmonary. Well, you can't see the pulmonary valve because it's not there. Well, it's pretty, like you see one little cusp, which is not really functioning properly. And you probably don't believe me because normally you can't see the pulmonary valve that well, but there is a better picture if I can find it. So that's just showing that pulmonary, because of the volume overload, the pulmonary artery does dilate as well, and the whole the pulmonary tree dilates. here, this is a better picture probably of the pulmonary valve. So you can see probably there's just like remnants of a leaflet more than anything else, but not really. You'd expect it to look like the aortic valve. You'd expect some proper cusps in there for a normal person, but there's not really anything going on there. And then when we put the color Doppler over it, it is kind of as you'd expect. Some good going regurg there. And then with the continuous wave across, this is the regurgitant area, and you don't see this very often, and this is severe PR because it's quite an abrupt cutoff here. So normally it looks, the regurg trace looks a little bit more square, but this is showing severe regurg. And I thought there were some more pictures, so I'll just see if I can find them. Yeah, here we go. So again, short axis. The color on top. It's probably a bit of a better picture. And yeah. Okay, so there's that. And then, so remember I told you that there's another very common complication from after a tetralogy of fellow repair. You remember what that was?
No, I don't think I can. Sorry.
So is it the residual VSD?
VSD, beautiful.
Oh.
VSD, yeah. Okay, so, and he has a VSD. I can. Just gonna, so you can kind of see it. You can kind of see it there. If I can convince you that there's something there. Maybe it's actually in the, yeah. Okay, so yeah, okay, here we go. So so there's a VSD in this image as well. And this would be, we'd be looking for a perimembranous Vsd. There's many different types of VSDs. I'll show you a picture in a second. But this is one that essentially you're looking between the tricuspid valve and the aortic valve. And then this communication here is the VSD. There's a very small residual VSD. Can you guys see that? That's where you look, and it's kind of in this area on your short axis view. And in your, you can see it on your 4 and 5 chamber as well. If I can convince you, maybe there's a bit of a VSD here. Not the best one. There's a very small communication there as well. And it's sort of just, you see it just between the aortic valve and the tricuspid valve in many views, in any view that you can see it really. Okay, I'll show you the picture I'm talking about. And this is how you diagnose what kind of VSD it is. Okay, I'm just going to share the screen now. So this picture, I really like this picture. So can you see this picture here? Can you see it? Is it big enough?
Yep.
Okay, cool. This is a really good website. So, so your membranous or perimembranous, it's the same thing. VSDs, you'd expect to pick them up in your short axis aortic valve level here, just between the aortic valve and the tricuspid valve, which is where we saw it. And then you can also see it on your 4-chamber view. 5-chamber apical view, again, kind of between the aortic valve and the tricuspid valve. And sometimes you can see it. There was a picture on this case, but I couldn't find it, where you can also see it in your parasternal long axis or long axis view. And it can be, again, it just sort of just below the aortic valve. So he has kind of all of the complications that you'd expect from tetralogy of Fallot, and then it's become severe. So he went on to get a pulmonary valve replacement and is doing much better. Yeah.
Benny, the overriding aorta, I actually wouldn't know what that would look like on echo. Can you just talk through that?
So you can't really, doesn't really look like anything on this, on the echo, because when we would see them, they would have had the VSD repaired, and then you can't really, like, the shadowing from the repair meant that we couldn't really see the aortic valve very well. You see how it's like half the aortic valves dropped out. Oh, sorry, yeah. I'll change back to the other screen. Sorry. Yeah, so like half the aortic valve has dropped out. I don't think it looks like, it doesn't look like anything specific, to be honest. Post-repair, I don't know about pre-repair. The thing is, like, I'm not an expert on congenital heart disease in the infant, because I don't know if you've seen how they scan. Have you seen how they do pediatric echoes? Okay, no. So it's upside down and back to front and all kinds of crazy. Like, it really messes with your head. And the convention for echo has developed completely differently in pediatrics than it has in adults. So the way, because of all the incredibly complicated anatomical defects you can get in babies, the way that they scan babies is actually anatomical, but the parasternal is the same for some reason. So the parasternal, they'll scan it the same as an adult, but then with the apical, it actually flips. So you see this triangle is actually the other way around. So it goes like that. So it's an upside down fan shape. And then, so you have the ventricles on the top of your screen and the atria at the bottom. And the reason they do that, no, sorry, that's not right. You have the ventricles at the bottom of the screen. And the reason they do that is when you scan it, is so that you're looking at it anatomically. So you don't have to flip it around in your head or anything like that. It's just looking at it anatomically, so they can trace where the arteries go and the defects and all that sort of stuff. So same with the subcostal view. It's different to how we scan. Very, very complicated. It really messes with your head. And it's really hard just to even to figure out what's normal.
Yeah, I wouldn't cope.
Yeah, it really messes. So that's, I thought it was bad when, like at the Mayo Clinic, they scan backwards. Like they flip everything right and left. They flip everything. So you're, what we normally see on the right is on the left of the screen. So then when they, even when they try and correct it, they'll flip their images when they're presenting and stuff at international conferences, and the ECG is going backwards. That's how you can tell they flipped it. So it's really, really, yeah. So echo is not standardized everywhere in the world, amazingly enough, if you can even believe that. Okay, so that's pretty much the main stuff on this case. So just very quickly, we'll go through one more case, which I thought was interesting and I kind of struggle with. So I'll just say up front that, so this is a case of a bicuspid valve with an aortic, a coarctation of the aorta, which has been corrected, which has been repaired in infancy. He still has a bicuspid valve, but the coarctation's been repaired. It's interesting because about 50% of people with a coarctation have a bicuspid valve, but 10% of people with a bicuspid valve have coarctation. So if you see coarctation, which we're more likely to see on a scan, on a CT scan, go and check for a bicuspid aortic valve because there's a very strong correlation, and even vice versa. And even though there are measurements you can do on echo and everything, it's actually better to just get a scan. So other imaging is better at quantifying the degree of stenosis at that coarctation at the isthmus than echo. Echo can give you an idea of severity, but it's actually not the preferred method to grade how severe it is. The CT scan can also tell you about all the complications, like you can get dilations and aneurysms and dissections and things like that. So that it's a better modality for that. So yeah, so I'll just show you a few images. So I think it's pretty interesting. Okay, so yeah, okay, so Ben, what do you think of that?
So I'm looking at an MO trace through the aortic valve on a parasternal long. And just before I look at the MO, just with regards to the still up the top showing where the trace is going, the aorta looks dilated immediately distal to the aortic valve. I'm not sure where the coarct was that was repaired, but it looks aneurysmal or dilated at the very least. But again, I don't know where the repair was, and if that's just an artifact that I'm seeing there, consequence to that. With regards to the M mode trace down the bottom, where am I in the cardiac cycle? So what I would be expecting to see here, so what I would be expecting is that there'd be I'm not sure how to, it doesn't look right. I don't know how to define it any better. That sounds really bad.
Okay.
Yeah.
Some technical difficulties. All right. Yeah. Okay. So, so what you expect is a box shape.
Yeah, that's right.
In systole, and then.
As I say, what I'm getting is at the distal cusp. It's not, I wouldn't be expecting it to go up like that, would I?
So
because
the diastolic part of the picture.
I've got the valve cusps opposing. Are they?
Yeah, they are, but it's offset, so it should be in the middle.
Yeah. Okay.
It's offset because because it doesn't have 3 leaflets to its valve, and you're not cutting it through the middle of one of the valve. So
not closing in the center.
He's not closing. Yes, thank you.
That's what I was trying to get across. I couldn't.
Yes, that's right. Okay, so
asymmetrical.
It's asymmetrical. Very good.
More medical sound. Good choice.
Good. I speak good English. Okay, so so can I convince you on this image? I've slowed it down, but you can see like he's got one big cusp and then one little. It opposes lower down.
Yeah,
that's what you're seeing on the M mode, and that's a pretty classic sign of a bicuspid valve. It doesn't always work out because, I mean, depends on how you cut it. You can make them look equal, so it's not not super reliable. You want to look at it. In what view do you want to look at it to make sure it's bicuspid?
No, I don't know.
Which view do you get the best?
Short axis.
Yeah, short axis view of the aortic valve. So
because they have two cusps that are fused and then a free cusp, don't they? Isn't that why it's bicuspid? So they'll have a sort of dominant and a larger and a smaller cusp.
That's really good point. So the vast majority, like 90 to 95% plus of bicuspid aortic valves are going to be not true congenital bicuspid aortic valves. They're the valves where you have fusion of the leaflets, of two of the leaflets. So on the short axis, you still see that kind of Mercedes-Benz sign when they're when it's closed. But then when it opens, one of the raphe is completely fused. So you get a functional bicuspid valve. Yeah. This actually, what do you think about this one? What do you think of this view?
It looks like, actually.
What do you think, Louise?
I think it looks like a bicuspid.
So it's between the right and the left?
I don't think there is a fusion.
Isn't it?
I think this is a true bicuspid valve.
Well, what about
I can only see two leaflets.
What about this down here?
So this is the aortic valve annulus. So that's the other thing with that's the bike. That's a good point. With a bicuspid valve, the aortic annulus is oval. With a true bicuspid valve, sorry. When it's not a true bicuspid valve and you just have fusion of the two leaflets, it's more round and it's more like a normal annulus. So this is a pretty oval shaped annulus, and then you have a bicuspid valve. This leaflet is bigger than the other one, which is probably what's a bit confusing, but it's just two leaflets. There's no nice, round circle with the Mercedes-Benz kind of sign. Can you guys see that? I'm not selling fairy tales. And that's another view you kind of see. I mean, yeah, so this is a true bicuspid valve, which is very rare. It's like a couple of % or something of all bicuspid valves. It's very rare. And then I'll just cut to the chase. Okay, so Lewis, what do you see here?
I'm not 100% sure, Betty. Sorry.
Is
it? Oh, okay. Yep. Sorry. Thank you. I see aliasing flow in the descending aorta. Then.
So what's the next thing you do?
Put a pulse wave gate in the descending aorta, and I would look to see the direction and velocities of flow.
Okay. What else can you do? What do you want to know? Like, what do you,
oh, sorry. I'll let you finish the question.
What are you looking for with the pulse wave?
So I'd be thinking about the coaction, and I'd want to look at the continuous wave and compare it to the pulse wave and step the pulse wave down through the descending aorta.
Yeah.
And then I'd be thinking about maybe aortic regurg as well.
Yeah, nice. So I'm just going to whiz through this because we're running out of a bit of time. So yeah, so you get very high velocities with the aliasing as you expect as it goes through that very narrow part of the aortic coarctation. You get high velocities on your continuous wave. I don't have the pulse wave. I don't have images of the pulse wave Doppler stepping down, but that's exactly what you do. And then the other thing you would do is the abdominal aorta. Yeah, I don't think they actually did it, but I do have pictures here. Just share. Okay, cool. So this is abdominal aortic pulse wave. So sometimes the abdominal aorta can give you a lot of information that's relevant to the echo. So don't forget, you can do, so this is normal. So it's normal to get like a sharp upstroke in systole and then nothing really in diastole, or very little in diastole. But when you have coarctation, that's this one down here. So you get because of the obstruction, you get a slow, the obstruction upstream, get a slow upstroke, and then it kind of gradually goes down, and you've got continuous forward flow in diastole. And just wanted to show you, okay. And then what you might see in a severe, so he has probably a mild residual stenosis or restenosis after his repair. But in a severe one, this is what you'd see. You'd see this, I think it's called a Saber-Tooth Pattern. And again, it's a continuous flow in diastole. You have very high velocities in systole, and then continuous flows in like high velocities in diastole as well, which you wouldn't expect. You expect it to be basically nothing. And then if you're above the obstruction and you're looking for severe aortic regurg, that's the opposite. So you get reversal, diastolic reversal. It would go on the other end of, on the opposite side of the baseline. Does that make sense?
Yeah, that does. Yeah.
But like I say, you want other imaging to look for the degree of stenosis and the complications. And then clinically, you can look for discordant blood pressures from upper body and lower body. And the way that undiagnosed coarctation can present is with extreme hypertension.
You can auscultate their back and hear a murmur over their posterior ribs.
Oh, really?
RSCP can include that. So, because they get if the coarctation is low enough, so if it's at the roof or something, you won't. But if it's a bit lower past the other side of the arch, and you've got collateralization of some of the vessels that come off, so you get these really prominent vessels, and you can hear like a whooshing murmur over their ribs.
In the middle of the back, did you say?
A bit more lateral, sort of mid sternal shoulder blade. That word.
Yeah.
The bone.
Your English is very good as well, I see.
Yeah. Down their ribs, you can hear a murmur, coarctation.
Oh, very cool, very cool. Okay, cool. And I think that's all I wanted to. That's all I wanted to show you guys. I hope that was interesting, and I hope it was relevant. I thought it was interesting.
That was great. I feel like that's more and more relevant, as you were saying.
Good. Yeah. I think so. I mean, if I've seen it, I haven't been here that long, and if I've seen it, then it must be pretty common. That's my reasoning. Are there any questions before we finish up?
No.
Okay, cool. All right.
No.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.